So I'm going to share with you the summary of our BCA. We started with the presentations. I'm just going to show very briefly a summary of each presentation, and then at the end we had the consensus discussions for the first revision, which I am also going to show a little bit of the process in a very brief way. We started with the newest VCA transplant, vascularized composite allotransplantation, which was performed in Mount Sinai, led by Eric Genten, and it was a trachea transplantation. He showed his patient, which was transplanted in January of 2021, so far with no rejection for fistula, and he highlighted that there was that this type of transplant is very helpful for defects over 6 centimeters, and he shared with us that so far what they have learned is that it is possible to do it, that standard immunosuppression appears to be effective, and he showed a graph of the chimerism which was lost over the first 6 months or so. Our second presentation was by Kurt Suchulo from the Mass General Hospital, who also was the lead surgeon who performed the first penile transplant in the United States. He showed a 6-year follow-up on his case with successful outcome, good urinary function, sensor return. He reported at 2 years with successful sexual function, and the patient is doing well. He also briefly mentioned the second penile transplant that was performed at Johns Hopkins also in his presentation. Our next presentation was by Jake Dimitris and his collaboration with the Baylor group on uterus transplantation. He highlighted some of the specificities of uterus transplant, which are helpful for other organs, and one of them is one that is a transplant that is temporary. Transplant is not meant to be a long-lasting transplant, and also that per protocol they are able to stop immunosuppression and therefore study the mechanism of rejection in a more longitudinal way. He also concluded that in terms of antibody sensitization, they're seeing more DSAs than parental specific antibodies. Our next presenter was Averina from the University of Gothenburg, who presented their work in 163 biopsies in 7 patients with a follow-up of 36 months. They have presented here about their proposed classification system for uterus transplant, and she mentioned some of the conclusions, which is that mild rejection occurs without clear association of outcome, which is something that's been seen by other groups as well as endarteries in larger arteries, and some of the other conclusions that you can see listed in the slide. Our next presentation was by Leo Riella. He presented several of his very elegant mechanistic studies where he's comparing VCA both for specificity in rejection as well as how it compares with other solid organs. And importantly, he presented one of his papers where he published in collaboration with Emmanuel and Kohler, published in 2019, about the marker of severity specific for VCA rejection being the serum MMP3. Our next presentation was Shah Kanitakis, who is probably the dermatopathologist who has the most experience in skin-containing VCA. He presented his personal experience, which, as you can see, is very vast, from face to hand, describing his findings and reports on small vessel vasculitis, as well as antibody-mediated rejection, chronic rejection, and graft vasculopathy. And our last presenter was Simon Tabo from the program. He gave a very nice overview of basically the current state of treatment for acute rejection in VCA. Mostly he sees upper extremity transplant, but he gave a very nice review of what is considered typical and atypical, with a discussion of that, considering the lower numbers, as well as an overview of immunosuppression, and he shared with us some of what he thinks are future directions in this area and the unique advantages of BCA, as well as some drug delivery systems that are taking place currently with several groups working on it. The last part of our session was the discussion for the first revision of the classification. I'm going to just summarize. We continue with, as much as possible, applying the NIH Consensus Development Program system, which is based on a broad non-advocacy independent panel, freedom from scientific or financial conflict of interest. We perform a systematic review of the literature. We have the invited speakers, and we have predetermined questions that define the scope and the direction. The conclusions are published in a peer review, and when we convene every 2 years, as we here at BANF. This is the classification system, which was published in 2008, but was finalized at BANF in 2007 in La Coruña. Just to put a little bit of perspective, currently there are less than 300 skin-containing VCA recipients reported in the scientific literature, compared to over 200,000 kidneys. So if we feel we know this, this puts us a little bit in perspective, and if we continue learning from the inferences in solid organ, we still have a lot to learn. This is a timeline of the first revision. We started with gathering information in May of 2016, and then I'm going to walk you through very briefly, but this is just like an overview of the events up until yesterday. Our first survey was sent out in 2016, and we organized a first international workshop. Basically what you see is the amount of agreement or consensus. The more green is the more consensus. The green is actually 8 out of 8 in terms of consensus. And basically the consensus is that start looking at the first revision considering the vascular changes. We then perform a second survey. We actually did a survey for pathologists for the diagnosis of rejection, as well as a separate for clinicians into what made them treat rejection. And this is just a summary. The most number of our skin-containing samples are seen by dermatopathologists, followed by transient pathologists and general pathologists. Out of all the people who answered the survey, 100% use the BANF system, which is a powerful number. This is just a summary of how we designed the survey, which was basically on very important, non-important. And for the purpose of this revision, 2 big topics were loud and clear, which was the need for inclusion of the vascular changes. But we also heard that there were not any features that people considered important that were not included already in the classification system. We looked at the literature, and the contributions from Ivy Rosales in her preclinical model were very important, and she actually proposed a systematic pathological component to score these type of lesions. We also continue learning from kidney and looking at how they have been, or you all have been working on this for many years. So what we did is basically we compare those to the VCA specific preclinical from Ivy, as well as the kidney that the BANF have been working for decades. And where we sort of put it, compare most were similarities for arthritis as well as vasculopathy. So then based on this, then we went ahead and did another survey, which we sent out. This was very focused to pathologists for the revision, which basically were asking about arthritis, vasculopathy, and microvessel thrombosis specifically for terminology, definition, scoring, and reporting. We got the results. We started the consensus discussions again last week, and then we finalized it yesterday with a consensus achieved for the first revision of our classification system, which basically it was agreed to keep the table and then move with adding the vascular changes. And this is just a draft of the discussions from yesterday afternoon, which will be added in the manuscript as a meeting prepared that will be in preparation. So as a summary, we have refined the accepted criteria with the first revision on consensus in this setting. As every other BAF is a living document, and we will work to disseminate these to the healthcare practice as well as the transplant community. And I would like to finish with the most important slide, and it's by really giving credit to the intellectual force of this work. This is a combined wealth of knowledge and experience in dermatopathology, transplant pathology, general pathology, clinicians, VCA, and certainly Brad and Cynthia with a wealth of knowledge in the BAF process, and all the attendees that have taken place and have participated since 2016 towards this first revision, which was finalized yesterday. Thank you.
So great to see, really. Though when you started back then, there was a handful of VCAs done in the world.
There were only 6.
Yeah.
There were only 6.
15 years later, branching into areas.
Right. But also, BAF was the first setting where VCA was recognized as an independent part of transplantation. So there's a lot of history in this.
Okay, we will start the body transplant work.
And the body, right?
Okay, with that, look, we were early. Thank you again for all of you contributing. And you see every organ, every group has a plan, and we will coordinate that. And looking forward to see everybody 2024 in Paris. Alex is buying drinks. And before you leave, check your surroundings. Jiggy has lost his USB stick in the room. So I think I would say all his talk of his career on that stick. So it's kind of important. Or was it in the other room?
Yeah.
Just found it.
I hope, okay, then don't check your surroundings. But travel safe, stay safe. And if you have some time left in Banff, enjoy it. And I really look forward and I'm energized to see you all early in 2024. That, meeting adjourned.